Of course, those are the two main stories we are following for you on Saturday Weekend Prime. Something I didn't mention within our sports segment is that Manchester City has defeated Chelsea by a goal to nil. I'm sure most Chelsea fans are sad. Anyway, it's about time we go straight to our Health Digest interview. We have Dr. Massey with us here. Dr. Massey, good evening. I'm sure you have something for us.
Most definitely. And earlier today, during our 9 to 10 p.m. bulletin, we focused on Naima Said. She was a 24-year-old who's been struggling with heroin addiction. And finally, she has overcome that addiction. And that forms the basis of our discussion: drug use, drug rehabilitation. And with me is Dr. Massey Carranza Cubitt. She is the head of Drug Rehabilitative Services and the Medically Assisted Therapy Clinic at Mathare National Teaching and Referral Hospital. She teaches psychiatry, addiction psychiatry at Mathare MTC, and she holds a Bachelor of Medicine and Bachelor of Surgery from the University of Nairobi and her Master's in Psychiatry from the same university. Other training she's had is on addiction medicine training from the University of Maryland and Columbia University together with UNODC. She's been a UNODC consultant on addiction training and the ICAP technical advisor on the MAT, or the Medically Assisted Therapy Program implementation in Kisumu. Thank you very much, Dr. for joining us this evening. And next to her is Dr. Tamu Danielle. Dr. Tamu is the PEPFAR country coordinator in the U.S. mission to Kenya. PEPFAR is the President's emergency program for AIDS relief. She is the representative also of the Office of Global AIDS. Sorry, let me take that again. She's a representative of the Office of the Global AIDS Coordinator here. She has worked with PEPFAR teams in South Africa, Zambia, and Uganda. She has over 25 years HIV research experience at Emory University, University of North Carolina, Chapel Hill, Georgia State University, and the University of Witwatersrand in South Africa. She has research and teaching fellowships at Duke University and the University of Georgia, and she holds a Bachelor of Arts in Psychology from the Hampton University, Masters in Public Health from Emory University, and a Doctorate in Public Health from the University of Georgia. And these two ladies, doctors, will discuss with us this topic of drug rehabilitation and drug use. And I'll start directly with you, Dr. Carranza. Why are we focusing on injecting drug users?
Thank you, Dr. Massey, for having me here. And injecting drug users have become a focus in our healthcare systems recently because of the emerging needs to address their needs, especially in relation to HIV and AIDS. We've noticed that there's a higher prevalence of HIV amongst people who inject drugs, and this comes about because of two main factors. One is the injecting risk. When they inject, they share needles and syringes, and this causes transmission directly of the HIV virus to each other. Then the second one is through the sexual transmission. Some of them will engage in risky sexual behaviors because drug use definitely impairs your judgment, and you may end up having sex without protection. And remember also that even those who are injecting drugs and they are exposed to HIV, they have sexual partners, some of them multiple sexual partners, some of them who are using drugs, some who are not using drugs, and therefore they end up spreading the virus to them. On top of the HIV and other medical risks that they face, including hepatitis B and C and other infections, there is also the psychosocial implications and the need to rehabilitate them also to be socially functional and also economically beneficial to the country. So that is why there has been an increased attention to the needs of this special population.
So does this mean only injecting drug users or all other forms of drugs, regardless of how they are taken? Because in this we also include alcohol and tobacco smoke, which is more prevalent and almost the acceptable drug used in society. So does the risk of HIV and AIDS involve all these drugs, or is it just at higher risk with those who are injecting or using hard drugs?
Actually, when you talk about injecting drug users, they're just a small proportion of the people who use drugs. We have people who use other drugs, and even those who use heroin, because the main focus when you talk about injecting drug use, it ends up being at heroin. Some of them will smoke, and some will inject. But even those who use alcohol, cannabis, cocaine, and other drugs, they're still at risk of getting HIV transmission, mostly because of the risky sexual behaviors they may engage in when they are disinhibited by the drug use. As you know, that drugs affect the brain functioning, it affects someone's judgment, and therefore exposure to HIV/AIDS may increase. However, the risk to injecting drug users is much higher, and we find that prevalence amongst this population is actually more than 3 times that of the general population.
Okay, thank you. Now, Dr. Tam, which regions have PEPFAR focused on in Kenya, particularly for the issue of injecting drug use and trying to rehabilitate the people who are using this heroin, for example?
Actually, PEPFAR has worked across 7 counties, so Kiambu, Kilifi, Kisumu, Mombasa, Malindi, Nairobi, and we're actually going to open a MAC clinic in Kwale on Monday, October 2nd.
So why the focus on these 7 counties? Is there anything particularly special about these 7 counties, and why invest finances in these 7 counties?
Absolutely. So definitely, as Dr. Mercy just mentioned, this Dr. Mercy, but that one, as we try to make certain that we actually have HIV epidemic control in the country, we want to make certain that we are reaching key populations, and those particularly are persons who inject drugs. So we started this program with the government, with the Ministry of Health, both at a national and county level, to help us actually make certain that we get methadone in the right places at the right clinics in order for us to serve this very key and critical population. The coast, there's a great need in the coast. Clearly, Nairobi, with its large population, there's also a number of injecting drug users, but we're really trying to understand the scope of the problem and make certain that we have MAC clinics in each of the counties where you may find a large population of injecting drug users, to make certain that the methadone is there in order to help them actually kick the drug addiction and actually live positively, and if they're negative, to know that they're negative.
Okay. Dr. Carranza, we are talking a lot about methadone. What is this methadone, and why is it used for people who've been injecting heroin?
So if I may talk about the medically assisted therapy, what we are referring to as MAT, because methadone is part of MAT. MAT refers to an intervention, medically assisted intervention, alongside psychosocial interventions for these people who use drugs, in an effort to reduce or even stop their drug use, so as to reduce these health risks that they face and also address their psychosocial challenges. So in the medical component, we use a medication called methadone, which it is an opioid medication that helps people who are addicted to heroin stop using the heroin, because it reduces the craving of heroin. It helps somebody normalize and is able to function without craving and having the drug-seeking behavior. And this medication is provided under medical supervision, and it's a safe medication, and it helps somebody become rehabilitated while they're going about their normal life. They get occupation, they get jobs, they get linked back to their families and society. So methadone is a medication that is in that category called opioids.
Okay.
Yes.
So is it only for people who've been injecting heroin, or could also other people who smoke or sniff heroin still benefit from using this medication, methadone?
Indeed. The criteria to be on methadone is that somebody must have been using heroin and addicted to heroin. It is not for alcohol, it is not for cannabis, because some people confuse that it may be for any other drug, including cocaine, but it is specifically for people who use a class of drugs we call opioids, and that is where heroin falls under, because it's the biggest public illicit drug used publicly in Kenya. And therefore, methadone is specific for those persons who inject, smoke, and sniff heroin.
Okay,
yes.
Thank you. So, Dr. Tamu, do we know how many people are under the MAT clinic or are using methadone under PEPFAR funded, obviously, throughout the country?
So PEPFAR itself is funded, the money comes from the U.S. government, from Congress, and then we have actually implementing agencies. So USAID has nearly about 2,000 persons. USAID funded implementing partners are actually serving about 2,000 persons through their methadone clinics, and CDC funded clinics are actually treating about 1,500 persons who are actually overcoming drug addiction through methadone-assisted therapies.
Okay. And what costs are we looking at to, let's say, run one MAT clinic, and what costs are we looking at countrywide to just keep these persons under the MAT clinic in the 7 counties that you had mentioned?
Actually, PEPFAR right now, in the fiscal year that we're implementing now, we estimated to have about $1.5 million that were going towards methadone clinics, and in the next fiscal year, we're going to have about $2.7 million so that we can actually make certain that we provide the commodity, the methadone itself, across all the clinics. We provide technical assistance, and it's the counties and the national government that actually work to make certain that we have the staff and the facilities in order to make certain that methadone is there for people to overcome their drug addiction.
Okay. And Dr. Carranza, I'll come back to you. And one of the questions that many of our viewers and people have been asking is that how is it like to go through the methadone clinic? Do these people, when they start clinic, do they ever get a time when maybe they relapse or they get lost in the treatment? What is their journey like through the clinics?
Addiction treatment is usually not an event, it's a process that begins right from motivating the person to accept that they need help. And therefore, when you talk about medically assisted therapy, it starts at the community level, where these persons who have addiction to heroin are identified at the community, and we have civil society organizations in the community who speak to these persons as they provide harm reduction programs to them and interventions to them, and then they educate them about the need to change, and those who are motivated enough to change and take up methadone program, they are linked to any of the existing methadone programs that's nearest to them, and it is a commitment that somebody needs to make, because addiction is a chronic disease. That means it's a disease that stays with somebody for a long time, and therefore they need treatment for quite a long period of time. And even when they've stopped taking methadone, they'll still require follow-up. So they will require to come to the clinic every day to take their methadone dose. And besides taking the methadone dose, there are other interventions they'll receive. There's HIV testing and counseling, HIV treatment, TB screening and treatment, screening for other illnesses like hepatitis and sexually transmitted illnesses, and they offer treatment in the clinics. And then there is also the counseling bit, the therapy. That is what actually takes almost 70% of the care. And methadone can be taken for as long as a person needs it. And in addiction, we don't talk of an end point to treatment. We talk of a long-term care. So we will recommend to somebody not to be on methadone for at least 12 months. And then some can exit at 12 months, but some may require it for much longer. It depends on an individual's how they are progressing in the therapy. Mm-hmm. And even after they exit the methadone maintenance, they are able to come back and continue the other interventions that we talked about, especially the counseling and the integration into the society.
So do they ever relapse to using heroin even after starting the methadone treatment?
Well, recovering from drug use is usually quite a challenge for most of the people. And it is not unusual sometimes for some people to re-enter the cycle of change, and some of them may relapse in between, especially when they are faced with undue stresses in life, or those who may suffer from associated mental illnesses. And when they relapse, there's always therapy that's available for them, treatment, but majority of them who are committed, once they're on methadone, because the medication helps them stop the craving to heroin use, most of them you'll find that they stop using heroin completely. But some stressors may come along the way and make them have a sleep. But what we tell them during treatment is that a sleep doesn't mean you failed completely. It's just part of your recovery. If you sleep, and you come back for help, that is beneficial to you, unlike when you sleep and you don't come for help.
Okay. And now that she said that treatment is long-term, there's no end point to addiction. And we know funding is always up to a few challenges, either renewal or, or it can be stopped altogether. Is PEPFAR going to continue with the MAT clinics, the medically assisted therapy clinics, indefinitely, or is there a time when then Kenyans have to rethink of how to sustain and keep these programs going?
Well, thank you for that. I'm certain that we understand that. PEPFAR was pretty much designed not to run indefinitely. So, while we are a long-term country planning on being here with Kenya for the long term, certainly the government of Kenya is very keen and is positioning themselves in order to make certain that they are able to take over the full methadone, all of the methadone clinics across the country as we move forward. However, PEPFAR is definitely committed to making certain that we serve this critical population and make certain that their needs are met. So we do have funding in the current year, we have funding in the next year, and then we will actually have to, I'm certain that as we reach epidemic control with this population, we will look to make certain that we have methadone in future years as well, alongside the government.
Okay. Maybe to add on to what she has said, is that the program currently as it's run, it's a partnership between the US government and the Kenyan government. And the Kenyan government is actually also spearheading the programs. And therefore, there is a plan for sustainability, even beyond the funding after PEPFAR. Yeah, so even currently, some of the things that they fund include technical support and funding for medication, but you'll find some things like staff. Myself, I work for the ministry, but I work at the methadone programs. So you'll find quite a lot of staff who are still government employees who are working in the programs. So, yes.
And the reason I ask this is that after the U.S. got a new administration, the State Department was doing an assessment of funding to African countries. And one of the questions that was raised was whether this funding that is given to African countries, PEPFAR being one of them, is causing African countries to have some bit of self-entitlement, or to feel entitled to these programs. And so that now raised the question, will we still continue having this funding, or is the government looking at other ways, or what will happen to these people if the funding is stopped altogether, or if the funding is reduced? So the question that has been there is, you have confirmed that the funding will be there, but is it the same? Has it been increased, or will it now be shrunk to, a smaller amount?
Actually, because of the government and because of the foresight that the country has, the U.S. government has actually increased its funding to Kenya, because the expectation is that this country will be able to show other countries the way towards epidemic control, not just Uganda or Tanzania, so not just in the region, but globally. So PEPFAR is looking for Kenya to really help us to understand how to reach epidemic control across the world. So with that being said, right now we have about $500 million that's being implemented now across all of our HIV funding in the country. And in the next year, we will move to $557 million. And in a place where flat funding means that you're good, increased funding must mean that we're really looking to you for some results and some great outcomes that really show, again, showcase and show the world how we can actually get to control of HIV.
Okay. Then my last question to you is, we had a time where the USAID, and by extension the US government, raised questions with our Ministry of Health in regards to accountability on some of the finances given to the Ministry of Health. And so this put at risk some of these programs that are funded by the US government. And the question was, will the accountability issues raised against the Ministry of Health, which haven't been addressed as yet, affect funding for some of these programs through the implementing partners?
The answer to that is absolutely not. Again, the amount that was discussed as far as Ministry of Health suspension was $16 million. There's still $484 million that's being implemented and used in the country to make certain that we do actually serve each and every person who's living with HIV in the country. So we're still doing that, and the ambassador has made certain that there's not one person who's receiving medication, not one person who's on ART, not one mother who's pregnant and doesn't know her status, that not one child is born HIV positive. If there's any way for us to prevent or provide services to each and every client in the country, each and every person living with HIV, they want to make certain that the funding is available and there to do so. So absolutely will not impact service delivery for persons living with HIV in the country.
Okay. And Dr. Carranza, we know we are facing very many strikes from the healthcare workforce in Kenya. Have the MAT clinics been affected, knowing that the users of the clinics have to go there on a daily basis? Have the clinics been affected?
Actually, most of the MAT clinics continue to function normally despite the doctor's strike and the nurses' strike, and that is because of two reasons. The first reason is the commitment by the staff working in the clinics. You say that we talk of MAT clinics being like the ICUs for in these facilities, because this is an essential service that somebody cannot do without. If somebody doesn't get their methadone, they'll not be able to go to work. So there is a commitment by the staff to ensure that there is continuity of services. So service delivery was not interrupted in most of the MAT clinics in the country. And secondly, the advantage of having the partnership. So there's some of the staff who are supported by the partners who are implementing partners in the various institutions. And those staff were there to back up if some of the staff were unable to come to work due to maybe intimidation by their colleagues.
Okay.
Yes.
Final comments from you, Dr. Danielle?
I would love to mention that, yes, this commitment that Dr. Mercy speaks about is exactly what I found when I went to the MAT clinic. And I would love to encourage all who may know someone who is receiving medically assisted therapy to understand that stigma and discrimination is very real. It is not as if a person has moved from heroin to still just yet another drug. They're actually doing things to change their lives. So the support that they need in order to be successful comes from you.
Thank you. Final comments from you?
I would like to say that the medically assisted therapy has really helped a lot of individuals and families and actually impacted the society, because when you change the life of one drug user, you actually change the life of an entire family and a community. And therefore, we need to make sure that these services reach more and more people, because there's still a big number of people who haven't been reached. As she speaks now, we've only reached less than a third of the people who are estimating to be in need of the services. So we need to reach wider and also destigmatize drug use and treat them instead of seeing them as criminals. It is a disease.
Okay. Thank you very much for your time. Thank you, Dr. Tamu Daniel. Dr. Daniel is the PEPFAR country coordinator in the U.S. mission in Kenya. And Dr. Massey Carranza, she is the head of rehabilitative services at Mathare National Teaching and Referral Hospital. That's it from me tonight. I'll hand you over back to Yusuf Ibrahim, and he will be discussing issues to do with police brutality that the country has been facing or seeing in the recent past. I'm Dr. Massey Correa. Until next Saturday, have a good evening.